You have been doing everything right. The calories, cut. The cardio, added. The labels, read. The water, consumed. The wine, skipped Monday through Friday without complaint. And still, you look down in the morning and the belly is there, still there, growing actually. And every time you walk into a doctor's office hoping for a real answer, you walk out with some version of the same sentence: eat a little less, move a little more. If that sentence has ever made you want to scream, I want you to hear me say this clearly right now. You are not crazy. You are not alone. In 30 years of practice, I have seen this exact pattern thousands of times. Women who were disciplined, consistent, and completely failed by the explanation they kept receiving. What I am about to tell you is something almost none of them were ever told, and it starts with one number that changes everything. Estradiol, the primary estrogen your body runs on, cycles between 50 and 500 picograms per milliliter across your reproductive years. After menopause, that number drops to somewhere between 0 and 20. That is a 95% reduction in the hormone that regulates not just your cycle, but your metabolism, your cortisol response, your insulin sensitivity, and how your body decides where to store fat. And here's what I want you to sit with. 80% of practicing OBGYNs have received no formal training in the metabolic consequences of that collapse. 1 in 5 women gets dismissed at the office when she brings these symptoms forward. 75% are left untreated. The diet industry never updated its math to include that 95% drop. The fitness industry still runs the same program on a 55-year-old body that it runs on a 30-year-old one. And the real mechanism, the actual reason the belly grows no matter what you do, has not been named yet. That is what we are here for today. The silence didn't start with you. Your mother lived through this. The weight that wouldn't move, the nights that fractured into pieces, the exhaustion that sat behind her eyes like something permanent. And she called it getting older, because that was the only language she was ever given. Before 2002, there was at least some momentum. Hormone therapy had been growing as a treatment option, imperfect but real. Then, in July of that year, the Women's Health Initiative released early results linking combined HRT to breast cancer and cardiovascular risk, and the prescriptions stopped almost overnight. What the headlines didn't carry, what got quietly buried in the panic, was that the study used synthetic progestins, older formulations, and enrolled women who were on average 63 years old. A full decade past the window where timing actually matters most. That distinction never made the front page, and an entire generation of women in their late 40s and 50s was simply left behind to manage a hormonal collapse with willpower and fiber supplements. What followed wasn't a correction, it was a retreat. Medical training, which had never prioritized menopause to begin with, most U.S. programs still devote less than 2 hours to the subject across 4 full years of school, became even more reluctant to engage with it. Physicians stopped prescribing hormones. They stopped asking about symptoms in any real depth. And women, who had already been taught not to make too much noise about their bodies, absorbed the silence and internalized it as a personal failing. The cultural environment did the same quiet work. Women over 50 disappeared from the conversation about metabolism and health. Their struggles got reframed as discipline problems, and the diet industry kept selling identical caloric solutions to postmenopausal bodies, never once stopping to ask whether the underlying model still applied after the hormonal architecture of that body had fundamentally changed. Here is what I need you to sit with. The gap was not accidental. The training deficits, the cultural erasure, the industry inertia, they all converged around one specific body at one specific stage of life, yours. And the window was closing the entire time. The years immediately following menopause onset, roughly the first 5 to 10, represent the period when hormonal understanding and, when appropriate, intervention carry the strongest protective effect on bone density, cardiovascular tissue, and cognitive function. That is not a fringe claim. It is established research. Not new, not contested, and most women entering that window right now were navigating it completely alone in a post-WHI medical climate that had decided the safest answer was no answer at all. They came in describing belly fat that hadn't shifted in years despite genuine, consistent effort. They left with pamphlets about portion control. They described a brain fog so dense it felt like a neurological event and were referred to therapists. They said something is wrong with my body and were told nothing was wrong. I want you to hold that moment, the first time you felt it and were dismissed, because something was wrong. It was real. The system just refused to name it. And I am going to show you exactly what it costs when the naming comes too late. So let me name this clearly, because it matters, and because I have spent 30 years watching what happens when it goes unnamed. The entity that failed these women is not a single bad actor. It is a system with specific, traceable gaps. Medical training stopped the conversation. A 2022 survey by the Menopause Society found that only 6.8% of primary care physicians felt genuinely prepared to counsel patients on menopause. Not undertrained, not rusty, actively unprepared. Meanwhile, hormone therapy prescriptions dropped by more than 80% in the 2 years following the WHI headlines, and that retreat became institutional. Women entering perimenopause in those years didn't just lose access to a treatment option. They lost the clinical language for what was happening to them. They came in with real symptoms and left with vocabulary that fit a different decade. Stress, lifestyle choices, age-related changes. And at the same time, the wellness industry moved in, not with physiology, but with product. Not with mechanism, but with message. Collagen powders and intermittent fasting for women who needed a metabolic conversation they were never offered. The supplement market aimed at menopausal women now exceeds $40 billion annually. And most of it addresses the symptoms without ever naming the mechanism underneath. The woman paying that price, the one sitting here right now, typically spends close to 7 years searching for an accurate explanation of what is happening in her own body. 7 years of modified meal plans and elimination diets and cardio increases that don't move the number. 7 years of being handed solutions designed for a different hormonal reality. And the generational thread running through all of it is a silence that was passed down like furniture. Your mother didn't name it either, because no one gave her the words, and her mother before her did the same. This is not ancient history. It is the clinical inheritance of women who are in their 50s right now, carrying confusion their mothers carried, in a medical environment that has only recently begun to ask whether the model it was using was ever correct for this stage of life. What I need you to understand, and this is the part that changes everything, is that the mechanism at the center of all of it is not estrogen alone. There is a second hormone, one that most women have never been told interacts directly with estrogen loss, and its behavior in a postmenopausal body is far more aggressive than most physicians currently recognize. That is what we are about to walk through together. Here is where I want to slow down, because this is the piece most explanations skip entirely. Estrogen is not only a reproductive hormone, it is a regulatory one. It has receptors in more than 400 tissues: the brain, the gut, the arterial walls, the bone, the bladder. Nobody drew you that map, and because nobody drew it, most women have no framework for why estrogen loss creates a disruption that does not stay in one system. The hypothalamic pituitary adrenal axis, the HPA axis, is the body's master stress circuit. Under normal estrogen conditions, estrogen acts as a partial brake on cortisol output through that circuit. Remove the brake, and the HPA axis runs elevated. Not because of a stressor you can name, because the hormonal architecture that kept it regulated has collapsed. Cortisol rises, chronically, quietly, without a trigger you can point to. And sustained cortisol sends the body one instruction: store. Preferentially in the abdomen, close to the organs, where fuel retrieval is fastest in what the body reads as a survival state. But cortisol is only the first thing going wrong. What is happening simultaneously in the brain, that is, the connection almost no physician is putting into the same conversation. Estrogen regulates the brain, not metaphorically, but mechanically. Serotonin synthesis, GABA receptor sensitivity, dopamine reward pathways, all three destabilize when estrogen falls. The anxiety that appears without a clear cause, the flat affect that resembles depression, the cognitive fog dense enough to feel neurological. Those are not psychological responses to getting older. They are the direct consequence of estrogen receptors going dark in brain tissue that depended on them. And they are frequently redirected to psychiatry. 30 years of watching this exact misreferral happen in medicine, and I still remember recognizing it in my own body. I was 52, sitting at my desk on an ordinary Tuesday afternoon, mid-sentence in a patient chart, when I reached for a word I had used my entire career. A plain word, not a clinical term, and it was simply not there. I sat still for a full minute. I was a physician, and I did not connect what was happening to me for weeks after that. That blind spot between knowing the science and recognizing it in yourself is exactly where most women get lost when a doctor calls it stress. And one more hormone is almost universally absent from the standard workup for women over 50. Testosterone. Not just men, women. Free testosterone can fall by more than half from a woman's lifetime peak to her mid-50s, without a single physician ever ordering the test. And here is what makes this genuinely difficult to see clearly. These mechanisms do not operate in parallel. They compound each other. Cortisol elevation drives insulin dysregulation. Disrupted sleep, a direct consequence of GABA destabilization, pushes cortisol higher still. Depleted testosterone accelerates muscle loss, which reduces metabolic rate, which means the same meal that processed efficiently at 42 stores differently at 54. And all of this is unfolding alongside a condition affecting close to half of all postmenopausal women that is almost never raised proactively in a clinical setting: the genitourinary syndrome of menopause, progressive deterioration of the vaginal, bladder, and pelvic floor tissue that estrogen has been maintaining since puberty. It is almost always framed as inevitable. It is not. It is treatable, but rarely initiated until a woman specifically asks, and most women do not know to ask, because no one told them it was a choice. What you are looking at is not one system failing. It is 4 distinct physiological systems failing simultaneously, reinforcing each other as they go. That is not aging. That is a hormone shift nobody explained to you. And what that compounded failure costs the body over the next 3 to 10 years, that is the conversation we are about to have. Let me explain what is actually happening in your body. And I mean the actual mechanics, step by step, because you deserve more than a summary sentence. In the first 3 years post-menopause, cortisol levels in women without hormonal support rise between 15 and 30% above premenopausal baseline. Not because of stress you failed to manage, not because of a life event, because the hormonal brake on the HPA axis, estrogen's regulatory effect on your stress circuit, has been removed. And cortisol at that sustained elevation doesn't just encourage fat storage in a general way, it directs it, precisely mechanistically, to visceral tissue, the deep abdominal fat wrapping around organs, driving inflammation, carrying the highest metabolic and cardiovascular risk the body can accumulate. Not the kind you can pinch, the kind the scale doesn't always reflect. And it keeps directing it there every single day, regardless of what you ate. That is the starting point. It gets more complicated from here. And then the insulin story opens, which is the layer that gets missed most completely. In the 5 years immediately following menopause, insulin resistance accelerates by 30 to 50% in a concentrated window that most standard checkups do not screen for and most physicians do not explain. What that means practically in your body. The same meal that processed efficiently through your metabolism at 42 now triggers a preferential fat storage response at 54. Not because you changed what you eat, because the hormonal signal governing how glucose is handled has fundamentally shifted. Your pancreas is still producing insulin. Your cells are becoming resistant to it. The glucose has somewhere to go, and with cortisol already elevated and estrogen gone from the receptor sites in muscle and liver tissue, somewhere is the abdomen. Not occasionally, consistently, predictably, every time. I want you to sit with that. It is not discipline that failed. It is a cascade no one drew on a whiteboard for you. I had a patient I will call Diane, who came in about 8 months ago. She sat down across from me and said, her exact words, "I feel like my body is doing this to me on purpose." She was 54. 2 years of intermittent fasting, almost no processed food, 45 minutes of walking every morning without exception. Her waistband had still increased by 4 inches over 18 months. When I ran her panel, cortisol rhythm, fasting insulin, HOMA-IR index, her insulin resistance fell in the range I see in pre-diabetic men 15 years older. The fasting, the restriction, the caloric deficit she had been sustaining for 2 years, all of it had been functioning, without anyone telling her, as a cortisol amplifier. I explained the feedback loop. Restriction elevates cortisol, cortisol worsens insulin signaling, impaired insulin signaling stores fat viscerally, and the cycle tightens the harder she pulls against it. I watched something change in her expression. Not quite relief, quieter than that. She said, "So I wasn't doing it wrong." I said, "No, the protocol was wrong, not you." Resting metabolic rate drops between 100 and 200 calories per day in the postmenopausal window, not from moving less, but from the direct loss of estrogen's thermogenic effect on lean tissue. Estrogen actively supports the metabolic rate of muscle at rest. Without it, muscle burns less fuel even when you are doing everything the same. And the muscle itself is declining, 3 to 8% per decade after 30, accelerating sharply once estrogen is gone. The primary tissue that burns calories is simultaneously shrinking and becoming quieter metabolically at the precise moment she is being asked to reduce her input. The arithmetic was never going to work. Cortisol elevated, insulin resistance climbing, muscle mass declining, resting metabolism dropping by the caloric equivalent of a skipped meal every day. And now she restricts calories further. What does caloric restriction do to a body already running elevated cortisol? Raises it higher. What does elevated cortisol do to insulin sensitivity? Worsens it. What does worsening insulin sensitivity do to abdominal fat storage? Amplifies it. She is not in a diet failure loop. She is in a hormonal feedback loop that caloric restriction itself actively tightens. The harder she tries, the more precisely she is pulling the mechanism in the direction she is trying to escape. That is the moment I want you to sit with. Not the belly that didn't move, not the diet that failed. The moment you first started to wonder if something was genuinely wrong, and then talked yourself out of it, because you had been trained to call it age, to call it stress, to call it not trying hard enough. You were never losing your mind. You were never imagining this. What you were feeling was real, physiological, provable. It just wasn't being proven for you. This was not aging. Your body was responding precisely the way any body responds when its primary metabolic regulator disappears and no corrective signal is offered. Every symptom followed logically. Every failed diet followed logically. None of it was obscure. It was documented, published, peer-reviewed, and simply not brought into the room with you. Someone decided that conversation could wait. That choice is what sent you home with pamphlets about fiber and walking pace. In the first 3 years, the visceral accumulation compounds. Hot flashes intensify in a third of women. Sleep deprivation pushes cortisol higher, tightening the feedback loop. In the 3 to 10-year window, bone density declines rapidly without symptoms. Cardiovascular tissue changes. Genitourinary symptoms progress. The long view, cardiovascular disease is the leading cause of death in women over 60. Fracture risk reaches 1 in 2 women over 50. Estrogen's sustained absence shows consistent associations with accelerated cognitive decline. Anxiety rates during menopause run at 70%. Depression rates double. She absorbs both shifts while being told her symptoms are lifestyle problems. The shame layers in. The isolation is its own clinical weight. It is what happens when a physiological event is treated as a personal failing. What changes is the question you walk into your doctor's office holding. Not, how do I restrict better, but, what is my cortisol rhythm? What does my fasting insulin look like? And is anyone here trained in menopause medicine? That is a different appointment. You are entitled to it. The shift I am asking, seeing your body as a physiological system that responded predictably to a hormonal event, not as a personal failing. You were never failing. The truth was simply never handed to you. A woman who finally has the language for what has been happening, who walks into the next appointment knowing which questions to ask, knowing what answer she deserves.